thank you so much for the introduction. So I'd like to start off with a question. When you hear the word sport, what comes to mind? Your favorite athlete? Perhaps it's more of a recreational means to stay active. The 2026 World Cup is coming up, so maybe that comes to mind. Or perhaps you have more of a business-oriented mind and often discuss the amount of money put into this industry. So there are so many things associated with this one word, so I'd like to narrow things down a bit from the physiology perspective and put the focus on contact sport. So whether it's head-to-head with another player, to the body during a tackle, or with a ball or puck, there's always the possibility of injury in contact sport. The focus of my research lab is brain health. So sport-related brain injuries usually fall somewhere between the mild to moderate categories and are often associated with these symptoms. What's really lacking right now are the methods we have for assessing sport-related brain injuries, which include CT scans, MRIs, self-reporting, and the SCAT-6. Unfortunately, the majority of sport-related brain injuries can't be assessed with an imaging test because structural changes won't come up. So we have to rely on questionnaires and symptoms reported by patients which vary from person to person. So in addition to diagnostic difficulty, it leaves us at a disadvantage in terms of understanding the effects on cardiovascular and cerebrovascular health. So where do we go from here? So one commonly used method is assessing blood-brain biomarkers. While there are several that can be discussed, the two I'll highlight today are glial fibrillary acidic protein, or GFAP, and neurofilament light. If we take a closer look, we get a better view of the blood-brain barrier, which is made up of tightly packed endothelial cells. However, physical injury can cause this barrier to break down, and what this does is it allows the biomarkers to more easily cross through and become more present within the peripheral bloodstream. And they also increase in concentration proportional to the severity of damage. So in 2020, McCrae and colleagues explored the association of these markers with concussion in college athletes. They sampled over 500 athletes and separated them into three groups: concussed contact athletes, contact sport controls, and non-contact sport controls. So blood samples were taken at baseline and at 4 post-injury time points in all participants. And what they found was a significant increase in GFAP concentration from baseline to the acute phase, and although concentration rapidly drops until 7 days post-return to play, it was still significantly higher than compared to baseline. And their neurofilament light results showed no significant change acutely compared to baseline and compared to the control groups. However, when the concussed group is further broken down, depending on whether or not they experience a loss of consciousness or post-traumatic amnesia, results showed significant differences between groups and compared to baseline. And this just supports the notion of neurofilament light being a better marker for long-term injuries and a better marker for more severe brain injuries. And their GFAP concentration showed similar trends even when further breaking down the groups. So what they concluded was that these findings support the use of biomarkers to inform the underlying physiological mechanism of brain injury. But blood drawing is still an invasive method, and our lab is looking for more non-invasive ways to assess brain health. So we used 5 different cardiovascular and cerebrovascular stressors as a means to assess brain health, and today I'll be talking about 4 primary outcomes, one being heart rate, mean arterial pressure or blood pressure, middle cerebral artery velocity, and posterior cerebral artery velocity. So for dynamic cerebral autoregulation, we use oscillations to drive changes in blood pressure and blood flow. And in our study, it was done using a repeat squat stand method. Next is the cold pressor test, in which increases sympathetic nerve activity and thus increases the responses in all of these measures. A neurovascular coupling test mainly targets the PCA, but also stimulates the MCA just to a smaller degree. A lower body negative pressure test, or LBNP test, targets heart rate alone. And the CO2 reactivity test, in our test it was hypercapnia, increases all of these measures. So these are the expected responses in healthy individuals. So similar to the McCrae study, Johnson and colleagues also compared concussed collegiate athletes to healthy controls. However, they only used the cold pressor test as their stressor. And while their work yielded significant results, including a blunted blood pressure and heart rate response in the athletes compared to healthy controls, we were interested in applying a sympathetic stressor without the confound of a blood pressure increase, which brings me back to why we use the LVNP test. So in addition to sympathetic activation, another key aspect of brain health is vasomotor capacity. It's been established since the 1940s that the brain is highly sensitive to changes in CO2. However, our study is the first to implement this method alongside several other stressors at multiple time points to be used as an index of overall brain health. So for today, results will focus on blood biomarkers, LVNP, and CO2 reactivity or hypercapnia. The purpose of our study was to first use the blood biomarkers as an index of injury in junior Canadian football athletes throughout a season. It was hypothesized that the markers would be elevated post-game compared to pre-game. Our second purpose was to evaluate cardiorespiratory and cerebrovascular function during LVNP and hypercapnia, and we hypothesized that responses to these tests would be blunted post-season compared to pre-season. So just an overview of the study. In season, only venous blood sampling was done, and it was collected about 24 hours post-game and 24 hours pre-game and 12 hours post-game in the athletes. In the pre- and post-season, LVNP and hypercapnia tests were conducted. The LVNP protocol consisted of 10 minutes of resting baseline, followed by the 3-minute stages at -20, -40, and -60 millimeters of mercury. So cerebral blood velocity was measured using a transcranial Doppler ultrasound, or a TCD. Blood pressure was measured using finger photoplethysmography, and heart rate was measured using a 3-lead ECG. The hypercapnia test consisted of 3 minutes normal capnic baseline, which was measured using a dynamic and tidal forcing system setup such as this, and we also followed it with 3-minute stages at +5 and +10 millimeters mercury once stable. So moving into our results, I do want to note that there were no diagnosed concussions during the season, and across all 12 games and 14 athletes, a total of 97 blood data points were collected. So overall, we saw a significant increase in GFAP concentration post-game compared to pre-game by about 17.7%. And while neurofilament light trended toward a decrease, it didn't quite reach threshold. So right now we do know that there are acute increases in GFAP and no changes in neurofilament light in contact football post-game compared to pre-game. Next up, we have our LVNP results. And what we found was that average or mean MCA showed no significant difference in response pre versus post-season. We saw the same thing with the PCA. Mean arterial pressure remained stable as expected. And the key thing is here with heart rate, although there was only a significant difference at -60 millimeters mercury, we did find a main effect of pre versus post-season overall when comparing the total average of the test, with post-season response being about 12% higher overall. So the key takeaway here is that blood pressure control appears to be more cardiac reliant at greater intensities of LVNP following a season of contact football. And lastly, moving into our hypercapnia results. So we had an increase in mean MCA as expected, but it was not significantly different post-season compared to pre-season. And a similar story with the PCA. Mean arterial pressure, again, we saw the expected increase as a result of heightened CO2, and while there was no significant difference pre versus post at each individual stage, we saw a small main effect and an increasing shift in blood pressure, but this only came to be about 6% higher overall. And lastly, with heart rate, a similar pattern was seen, a main effect resulting in an overall 11% increase post-season compared to pre-season, but no significant difference when looking at the interaction effect at each individual stage. So adding in our final key point here, we also now know that vasomotor capacity in response to hypercapnia seems to remain intact following a season of contact football. However, the implications of all of this are still yet to be fully understood. So a few acknowledgements. First and foremost, I would like to thank the Okanagan Sun junior football team for participating in this study. Without the participants, this of course would not have been possible. And next, I also want to thank all the collaborators from all the different institutions who helped with this project. Thank you to the funders and also for the sponsors, specifically Technovans who helped fund this trip partially. And thank you all for listening today.
great talk. So question out, you said that there was no there was zero diagnosed concussions throughout the season, which is rare for football. But did you think to still record concussion-like symptoms throughout the season, as despite there not being diagnosis, it may still be some persistent concussion-like symptoms that may lead to changes in the cerebral vasculature throughout the season? Is that something that was considered? Or?
That's a great question. So my advisor actually, Mike Simcoe, he's the one that actually collected all this data, and I've been analyzing it. So I did ask that exact same question. I think just because of the variability in the symptoms and the responses, they didn't use any standardized tests. But he did tell me that during the blood draws post-game, there were some times where the athletes would come in and say that they felt a little foggy that day. They also did measure kind of velocity. They were actually going to track velocity at the speed of hits. But I think that one they also were running into a little bit of trouble with it. There is also some IC and VA data that was collected as well. I just don't have that one, but it is ready. But that definitely would be something I think to add. And hopefully maybe implementing something else like the iStat alinity, where you take those blood biomarker measures right on the field and get the results within 15 minutes would be a good addition. And that's something also that I have a slide here for what it looks like. Let's see. Yeah, so specifically just referring to the NFL. So this iStat alinity is what I believe they did use, and that would be something I think would be kind of the next step in addition to keeping track of people's symptoms. Using this to keep track of blood biomarkers, because it gives them results within 12 to 15 minutes of concentration.
Thank you.
Any other questions?
I have a quick question. Hi, my name is Philip from Trinity College Dublin. Just have a quick question about your hypercapnia protocol. If you can maybe just explain how did you induce those changes in carbon dioxide? Yeah, first question, how does that system of yours work that you can use those changes? Because I know there's very fancy machines, like it's called the rest bracket, where you can make those very fine adjustments.
Yes, so the hypercapnia was used, the dynamic and tidal forcing system. It's just a laptop system where I do like the normal calibration to get like 3 liters, use a 3-liter syringe to do the respiratory baseline, set those up, also setting up our gas tanks, calibrating that to the system as well. It is a nightmare to learn, but really easy once you get the hang of it. So the system actually can keep track of the O2 and CO2, and it'll just automatically adjust when the person is on the mouthpiece. So the nice thing about the hypercapnia test is that based on all the tests that I've run for it, we don't see a lot of jumps in O2. We don't really have to adjust it. It kind of just keeps it at whatever their baseline values was. And the hypercapnia, it just slowly goes up, and then once it's stable, if there is maybe an overshoot like expected, we wait for it to come down. If it doesn't come down, I just have to clear the air on the system. So it's really about 1 or 2 buttons that I have to use. It's amazing and really, really good to kind of keep things accurate compared to baseline if we're trying to keep it comparable. But yeah, it's a little bit scary to learn at the beginning, but it's a really, really good system. Yeah, so it's a dynamic and tidal forcing system. I wish I could remember the name of the company, but I will find that for you.
Thank you so much. That's very nice. So, and then just maybe 2 little follow-up. Why did you choose 5 millimeters increases and 10? Is that sort of, did other literature do that, or how did you come to decide we're going to step increase it by 5 and then 10?
It's kind of been a standard for what I've seen just in the literature. I know some other labs will do maybe +4 and +8. We just do +5 and +10. It's kind of just been the standard for the lab. And for some people, +10 is very, very intense. Yeah. For a different project, I tested a long distance runner. Once he was at +10 millimeters mercury of CO2, he was breathing at 120 liters per minute. But other people don't feel anything, and they stay at like 20 liters per minute. So it's just kind of the standard across the board for our lab and kind of what we've seen in other papers.
Just one more quick question. So, there was no changes in CVR after the season. Could this be driven by changes in their fitness, perhaps? Does their fitness change across the season? Their cardiorespiratory fitness?
That's a really good question. I have so many extra slides and not one for that. That always happens. But I think that could be a possibility. The main thing when it comes to checking pre versus post responses, the issue that I know that they ran into was you would have a player who was maybe a starter at the beginning, and then by the end of the season they were injured, or somebody who didn't start and then became a starter as the season went on. So there are a couple of missing data points that could maybe play a role in why there wasn't any differences seen. But yeah, that is definitely a good thing to keep in mind for future studies, to maybe look at how fitness changed. If you have ideas on how to standardize that testing, I would love to hear it.
Good, thank you so
All
much.
right, thank you so much. All right, moving next, we have